Good afternoon, everyone. I'm very happy today to open this virtual conference. I'm more than happy about the organizers to have committed to maintaining this conference regardless of what's happening in our world currently. I think we all need to connect with each other and to talk about something else than COVID-19 for a couple of days. And it's really very, very good to have this exciting program and to be the one to open this conference. So I'm gonna give you an overview about the top 10 papers of the year. And of course, this talk is dedicated to our friend and colleague, Andrea De Luca. And I also like to take this opportunity to thank Charlotte Charpentier, who really helped me in selecting the articles and interpreting some of them. So this is what we're going to go through. Of course, given the current epidemic, I could not but talk about COVID-19 and HIV. Then we'll go through antiretroviral therapy with the NAMSAL trial and the cabotegravir and repeating long-acting latest data. We'll move on to PrEP with HPTN 083. And I know it's not published yet, but I think it's really important to talk about this study with these amazing results. We'll also talk about islatravir, and then we'll finish with HIV reservoir. So let us first start with COVID-19 and HIV. And with the first question, are people living with HIV overrepresented among COVID-19 patients? So I chose to present you the ISARIC prospective cohort with a focus on the UK data gathered between February 6th and April 18th, 2020. More than 1,600 patients with COVID-19 were enrolled in this cohort with a median age of 72 years, a median time between symptoms onset and admission of 4 days, and a median time between admission and discharge of 7 days. 49% of them were discharged alive, 33% died, 17% required ICU, and of whom 45% died, and 17 were still hospitalized at the time of the analysis. So when we look at comorbidities that these patients had, you see that here, the most common comorbidities were those who are already described within other studies. But as regards to HIV and AIDS, less than 1% of the participants had HIV or AIDS. So clearly, HIV is not overrepresented in COVID-19 disease. So if it's not, is it associated with COVID-19 mortality in those who develop COVID-19? So the first paper I wanted to discuss is the cohort study in public hospital in Cape Town, South Africa. The aim of the authors were to assess the association between HIV infection and COVID-19 mortality between March 1st and June 9th, 2020. And they used Cox proportional models adjusted on age, gender, home location, and comorbidities. Among more than 3 million participants, 22,000 had COVID-19 and 625 died. Among the comorbidities associated with COVID-19 mortality, we could find male, gender, age, diabetes, hypertension, chronic kidney disease, and HIV. As you see here on both graphs, HIV was independently associated with an increased risk of mortality among patients hospitalized for COVID-19 and among all of those who had a confirmed COVID-19 disease, with an adjusted hazard ratio at 2.14. On the other hand, another study, the TreeNet network performed in the USA, collected data on more than 15,000 individuals COVID-19. 49,763 were HIV negative and 404 were HIV positive. And they were matched one by one for BMI, diabetes, hypertension, chronic lung disease, chronic kidney disease, race, smoking, and gender. And the authors used propensity scores. While crude mortality was higher in HIV-positive individuals, after propensity score matching, there was no difference in COVID-19 mortality between HIV-negative and HIV-positive patients, which means that mortality is rather driven by the high burden of comorbidities in HIV-infected patients rather than HIV by itself. And finally, to conclude with the COVID-19 chapter, what about the severity of the disease in people living with HIV according to the antiretroviral regimen? So this is the study of the Spanish hospitals, 60 hospitals in Spain with more than 77,000 individuals followed for HIV. This was a prospective cohort between February 1st and April 15th, 2020. And the objective was to describe the incidence and the severity of COVID-19 in people living with HIV according to the NATI backbone use. They measured cumulative incidence of confirmed COVID-19, hospitalization for COVID-19, admission to ICU, and death. And all this according to an NATI backbone with a Poisson regression. And here is the flow chart of the study. 77,000 patients, of whom 236 had a confirmed diagnosis of COVID-19. 151 were hospitalized, 85 were outpatients. And you can see on the diagram, those who were admitted to ICU and those who were admitted in medical wards. And among those admitted to ICU, five died and 10 recovered. Among those admitted to medical wards, 12 died and 124 recovered. And you have in the box down of the graph, the backbone of NATI that they were receiving: abacavir 3TC, TAF FTC, TDF FTC. And you can see in all the boxes that the patients receiving TDF FTC were more likely to be represented among those who recovered rather than those who were receiving abacavir 3TC or TAF FTC. So these are the final results. As regards the risk of confirmed COVID-19 diagnosis, regardless of hospitalization, of being an outpatient, just the fact of having contracted COVID-19 disease. The risk was the highest for those receiving TAF FTC and the lowest for those receiving TDF FTC. This was the same among those who were hospitalized for COVID-19 with regards to the lowest risk with TDF FTC. However, the highest risk here was for those receiving abacavir 3TC. So the conclusion was for the study that the lowest risk of COVID-19 diagnosis and hospitalization could be associated with the fact that TDF FTC had a protective effect on COVID-19. So this remains to be confirmed by larger studies, and this could be interesting to perform such studies in people receiving PrEP who don't have any other comorbidities. So let us move now to antiretroviral treatment with the NAMSAL study assessing the efficacy of dolutegravir versus low-dose efavirenz in first-line CART. This was an open-label, non-inferiority trial performed in Cameroon. This trial enrolled antiretroviral naive participants with an HIV RNA above 1,000 copies per ml, and participants were randomized to receive either TDF 3TC plus low-dose efavirenz 400 milligrams versus TDF plus 3TC plus dolutegravir 50 milligrams once a day. The primary endpoint was to achieve an HIV RNA below 50 copies at week 48 by snapshot analysis, and non-inferiority margin was 10%. Here are baseline characteristics of the participants. I won't go through all the details of the table, but I just wanted to point out that a third of the participants had a pre-therapeutic HIV RNA viral load above 500,000 copies, and also a third of the participants had a CD4 cell count below 200 per cubic millimeters at baseline. So these are the patients that are the most hard to treat. So these are the results of the primary endpoint, which was virological suppression at week 48, which was achieved in 75% of participants in the dolutegravir arm and 61% of participants in efavirenz low-dose arm. So these results are a little bit lower than those expected with regards to what has been already published in the literature. I wanted to remind you that DTG efficacy in single was 88%, DTG efficacy in Flamingo was 90%, and efavirenz 400 efficacy in Anchor 1 was 82% at week 48. So clearly here we have lower percentage of patients achieving virological suppression at week 48 than those we saw in other trials. This might be due to the high proportion of patients with high viral load and low CD4 at baseline. Let us check for non-inferiority now, and you can see here that in the intent to treat population, the per protocol population, in the subgroups of baseline viral load below 100,000 copies or above 100,000 copies, non-inferiority was demonstrated, but there were no superiority of DTG versus efavirenz. So again, DTG is non-inferior to efavirenz 400 milligram for first-line treatment, but is not superior in this study. What about resistance? So HIV drug resistance was performed retrospectively on baseline samples. There was a predominance of CRF02, 57% in the DTG arm, 63% in the efavirenz arm. Primary resistance to NATI was low, 1.3%. However, primary resistance to NNATI was 6.1%, and this accounted for 37 participants, including 35 of them with efavirenz resistance associated mutations present at baseline. And of note, there was a high level of integrase genetic polymorphism, with 51 participants harboring the E157Q mutation in the integrase genes, which represents 8.4% of participants. Multivariate analysis did not show any association between the presence of primary resistance, including efavirenz resistance associated mutations at baselines, and the absence of virological suppression at week 48. So there was no impact of this primary resistance to NNATI or to integrase inhibitor at baseline on the outcome at week 48. There were 3 failures in the DTG arm, no DTG resistance at baseline, and no resistance emergence at the time of failure. There were 16 virological failures in the efavirenz arm. 5 of them had efavirenz resistance mutation present at baseline. 1 had efavirenz N3TC and TDF resistance at baseline. 2 acquired efavirenz resistance at failure. 3 acquired efavirenz N3TC resistance at failure. 3 acquired resistance to the 3 drug at failures, and 2 had no resistance detectable at the time of failure. So this is something very that we should look into, the fact that pre-existing resistance mutation, primary resistance, did not affect the outcome. However, the efavirenz arm seems really less forgiving than the DTG arm. There was more virological failure in the efavirenz arm, and in the event of virological failure, the emergence of resistance mutations was more common in the efavirenz arm than in the DTG arm. What we should also look out is that the mutation 157Q in the integrase genes, it is part of the French algorithm for possible resistance to DTG QD, and as you can see here, it didn't seem to affect the results. Let us move now to dual therapy with cabotegravir rilpivirine long-acting and the FLAIR trial, which was recently published in the New England Journal. In this trial, naive patients went through an induction phase of 20 weeks of oral DTG plus abacavir plus 3TC, and then after 20 weeks of oral triple drug induction, they were randomized to continuing this triple oral drug combination or to switch to a first daily oral dual therapy with cabotegravir rilpivirine and then monthly injection of cab plus rilpivirine long-acting until week 96. These are the results. As you can see here, more than 93% of the participants were able to maintain virological suppression in the dual therapy long-acting arm and in the oral therapy maintenance arm. And 4 of them discontinued treatment for lack of efficacy. 1 out of the 4 was the woman who had a false positive pregnancy test, and treatment was discontinued when the false positive test was performed. And by the time the confirmation showed that she was not pregnant, she resumed treatment and she had reached the protocol-defined virological failure, and then she was switched on another treatment. Regarding the 3 other participants who experienced protocol-defined virological failure in the long-acting group, all 3 had a BMI above 30, plasma drug levels in the lowest quartile, HIV subtype A with the L74I integrase polymorphism, and all 3 had emergence of NNATI and INSTI resistance-associated mutations at the time of failure. So let us look into those participants who were harboring an HIV subtype A and those who were harboring the polymorphism L74I in the integrase genes. As regard HIV subtype A, 8 participants in the long-acting group were harboring this subtype. 5 maintained virological suppression and 3 experienced virological failure. When we look at those who were harboring the L74I polymorphism, 54 participants had this polymorphism at baseline, and 51 out of 54 were able to maintain virological suppression on cabotegravir plus rilpivirine long-acting maintenance therapy. What about PrEP and the scoop with the cabotegravir long-acting efficacy within the HPTN 083 study that was presented this summer in the AIDS conference? So this is the study design. Cabotegravir injection performed every 2 months were compared with TDF-FTC taken orally and on a daily basis. First, all participants took cabotegravir orally or cabotegravir placebo for 5 weeks, and then, if they did tolerate it, they were switched to the step 2 phase of the study with cabotegravir injection every 2 months with TDF-FTC placebo orally, or placebo of cabotegravir injection every 2 months with active TDF-FTC taken orally on a daily basis. And this was planned to last for approximately 3 years, and then step 3 was a daily intake of TDF-FTC orally to cover the tail of cabotegravir. So these are the results. There were 52 HIV infections in more than 6,000 patient year of follow-up. And as you can see here, 13 infection in the cabotegravir long-acting arm and 39 infection in the TDF-FTC arm. So as you can see on the right-hand side of the figure, cabotegravir was not only non-inferior to TDF-FTC, but it was also superior to TDF-FTC. Let us look into these 13 incident HIV infection in the cabotegravir long-acting arm. The first 2, A1 and A2, had an HIV infection that was documented at baseline. So it means that they got infected between screening and baseline. So it's not a treatment failure. They got infected before starting the therapy. B1, B2, B3, B4, B5, in these patients, they got infected on the long-acting step 2 phase, but all of them had more than 2 weeks overdue delay between 2 injections. And they probably got infected between this overdue delay between 2 infections. So we can assume that they had non-protective levels of drug in the plasma, but we don't have drug concentration available yet for these ones. C1, C2, C3 were infected during the oral phase of cabotegravir. So we may assume that they had some adherence issues in this short oral phase, which might explain the fact that they got infected. And what is really challenging are participants D1, D2, D3, D4, D5. They got infected during the cabotegravir long-acting injection phase, and they did fully respect the interval time between two injections. So there is no obvious reason for them to get infected. And we really need to have pharmacological measurements for these patients and to check whether they had sufficient drug concentration in plasma at the time they got infected. Another long-acting drug is islatravir, which seems very interesting because it's given orally. And this is the study that was performed in male macaques. And they tested several doses of islatravir. This is the first study. Macaques were challenged with low-dose intrarectal sheave every week, and they received weekly oral gavage with MK8591, which is islatravir, 3.9 milligram per kilo per week for 14 weeks. You can see on the graph here at the bottom of the page that all macaques who were receiving islatravir at the dose of 3.9 milligram per kilo per week were protected, while all the controls got infected after a maximum of 4 challenges. Here you have HIV RNA that was measured in all the controls. In all of those who got infected had an HIV RNA detectable. And on the graph here, you can see the concentration of islatravir intracellular concentration of islatravir in PBMC, which were really as expected. So the next step was to lower the dose. So they performed the same study with islatravir 1.3 milligram per kilo or islatravir 0.43 milligram kilo per week. And you can see here that with both doses, 100% of the animals were protected, while all the control animals got infected. And here is the concentration of the islatravir at the dosage of 1.3 milligram per kilos at the end of the study, the washout period, and then the concentration when the 0.43 milligram per kilo study was started in the same macaques. And finally, the lowest dose of 0.1 and 0.025 milligram per kilos per week. And with these two low doses, 6 out of 8 animals were protected with the dose of 0.1 milligram per kilo, and only 2 animals were protected with the dose of 0.025 milligram per kilo. So this means that islatravir shows promising results at dose higher than 0.1 milligram per kilo per week in a macaque model, and this support future studies in humans with a monthly administration of islatravir taken orally once a month, and the studies are about to begin shortly. So let us move now to the reservoir section with 2 papers that were recently published with very interesting results. The first one assessed the reservoir in elite controllers versus patients who achieved HIV RNA below 50 copies on combined antiretroviral therapy. The first results that they were able to produce was that the proportion of intact provirus was higher in elite controllers, as you can see here depicted in pink, rather than in those who achieved an HIV RNA below 50 copies on combined antiretroviral therapy. And this was regardless of the integration sites. So the proportion of intact provirus is higher in elite controllers than in those who achieved control on antiretroviral therapy. The second interesting result is, where is this intact provirus located and what is the integration site? And you can see here on this picture that intact proviruses were more likely located in centromeric satellite DNA or in zinc finger genes of chromosome 9. Both locations are associated with heterochromatin feature, and this was significantly more common in elite controllers than in those who achieved virological control on CAR. So in elite controllers, intact proviruses are located in centromeric satellite DNA or in zinc finger genes on chromosome 9. And finally, they were also able to show that integration sites of intact proviral sequences from elite control were distant from transcriptional start sites and accessible chromatin of the host genome. This means that in these elite controllers, intact sequences of viral DNA are far from transcriptional start sites and accessible chromatin. Moreover, they also showed that integration sites of intact proviral sequences from elite controller were enriched in repressive chromatin marks. So all this contributes to the absence or the very low replication in these individuals in comparison to what happens in chronically infected patients. And finally, the last paper I wanted to talk to you about is the one who assessed the potential effect of compartmentalization and cellular residency on integration sites. For this study, authors gathered PBMC and lymph nodes mononuclear cells from cervical and inguinal lymph nodes from acutely infected individuals and from chronically infected individuals. They also gathered tonsils from CAR-treated individuals. And they did compare integration sites between the subsets of CD4, central memory, effector memory, and between CD4 and lymph node mononuclear cells. And this is what they saw. As you can see here, in acute, chronic, or CAR-treated individuals, there was little overlap between or within CD4 cell subsets or tissue compartments. There were only 8 shared integration sites over more than 3,000 integration sites that were studied. So this means that there is not that much of exchanges or traffic between compartmentalized CD4 in peripheral blood and in lymph nodes. So with that, I'd like to thank you. I wish you a very exciting conference and hope to see you soon on another occasion. Thank you.